Welcome to everyone to our second of 6 town hall meetings that we've been hosting for the past 3 years now as part of our Family Empowerment Month. Today's town hall is focusing on mental health. And as everyone knows who's on this, you already know who Families Together is, but just to give context, the reason for today's town hall is to talk specifically about the Office of Mental Health and the mental hygiene committees in the Senate and the Assembly, and to have people with lived experience, both family members and young people, to ask questions directly to policymakers and policy implementers about their lived experience and about how we can help to shape policy in New York State regarding mental health. As everyone knows, Families Together is the statewide family-run, family-governed organization that represents families and young people with lived experience in the mental health system and in multiple systems. And our motto is nothing about us without us, meaning that we have some expertise because of our lived experience that we can help to shape policy and to help implement policies that will affect our families and our young people. So with that, I'm thrilled to be able to introduce the Commissioner of the Office of Mental Health, Commissioner Sullivan. And also we'll be joined by legislators, the chairs of the Senate and Assembly Mental Hygiene Committees. But I'd like to first introduce Commissioner Sullivan.
Well, thank you so much, Paige, and thank you for having me here today. And it's a real pleasure to be here. I know there's going to be lots of questions, but just to say that I do believe that the budget that is presented by the governor this year is historic. It offers more for mental health than I've ever seen before. And that includes a lot for youth and families. So I know there's going to be lots of questions about it, so I'll talk about it as you ask. But it's actually, I think, historic, the commitment that we have and the opportunity we have if we all work together. So I just want to also encourage everyone, we're having some stakeholder meetings statewide. Please, in addition to today, give us all your input, everything that you think is important, we need to know, and we need to know from you how we should implement some of the things that are in the budget. So thank you. I'll end there and be available for all kinds of questions. Thank you.
Thank you, Commissioner. And we've been very fortunate to be joined by Senator Brouk, who is from the Rochester area and has been the chair of the Mental Hygiene Committee for a few years now. And we have found her to be an ally and a friend. So Senator, do you want to introduce yourself?
Yes, good afternoon. Hi, everyone. I just want to say thank you to Paige and Brad. Being here with you every year is such an honor to just take a moment out to make sure that we are listening to, like you said, all of the voices and those with lived experience, and very proud of the work we've been able to do over the past 2 years with me in this position. And we always know that there's more to be done, whether it's, creating more cultural competency, better investing in our youth and our families, and also really taking a hard look at the systems we have and making sure that they're treating everyone equitably. So that's always been my focus, and I look forward to hearing your questions.
Thank you, Senator. And I'm going to turn it over to Justice, but before I do, I just want our chair in the Assembly, Assemblywoman Gunther, is going to be joining us. And when she does, Justice, if we could just take a second to introduce her when she joins. So it's my pleasure to introduce Justice Wilcott, who is a member of our team at Families Together in the DEI department and also in the as part of the Youth Power team. Justice has lived experience and is going to be leading today's discussion. Justice.
Thank you. Good afternoon, everyone. Thank you all for joining us. My name is Justice Walcott. I serve as the Pilot Diversity, Equity, and Inclusivity Youth Engagement Specialist here at Families Together. I have my own personal experience with mental health and have both been directly and indirectly impacted by the mental health system. Just a pointer, as we course through today's dialogue, I want to gently remind everyone that we are here in a space where people will possibly be sharing their experiences and stories, and that is both extremely personal and extremely courageous. I ask that questions and responses alike be met with empathy, compromise, and open-mindedness. We are aiming for equity in this conversation, and that takes creative thinking and holistic thinking. So I think I can speak for many when I say that we are excited to engage in today's discussion. And with that, we can move into the first question. First up is Ms. Sarah Taylor, hailing from Rochester.
Thank you, Justice. Thank you, Paige and the team. And thank you, Commissioner Sullivan, for supporting our symposiums around the state related to mental health in communities of color. And Senator Brouk, you know how we feel about you in Rochester, and for helping to secure our first government contracting grant for our grassroots parent-led. So thank you for all of your work. First question. There is a stark inequity in mental health services for BIPOC, Black, Indigenous people of color and community. One way to address this is to put more emphasis and resources in non-clinical, non-standard practices, such as community-based and culturally responsive healing-centered models. There are standards in BIPOC communities like our own. New York State needs to meet communities where they are at. How can the legislator and the Office of Mental Health commit to intentional solutions like these and others that are led by BIPOC organizations that may not fit into the current Medicaid billable model?
All right, and to start off, we'll have Senator Samra Brouk.
Thank you, Justice. And thank you, Sarah. It's always wonderful to be in physical space or virtual space with you, both of us hailing from Rochester. And I'm actually going to take some of the language that Justice used when setting the stage for us and how we approach this conversation, because coming at this work with a lens of equity does often mean being creative, right, in how we do it. And so one of the ways, and Sarah, you actually touched on this, but one of the ways I think we do a better job of having these more healing-centered models, which, by the way, are these ancient models that our ancestors used, right, for all of time. And really, it's more in recent history that we've moved away from many of these community-based models. And so one of the ways that we can be creative is seeking out these sometimes small organizations that are incredibly grassroots based, right? And really finding creative means in which we can support them, which is one thing I'm very proud that we were able to provide funding to BIPOC Peak and other organizations that traditionally have been left out of the conversation when it comes to state law, state policy, whether their advocacy isn't heard or their funding isn't reaching them. And so we have to, I think, as Justice said, become more creative when we think about how we are using our state dollars. And the state really has to make it easier and more accessible to get those dollars. I think the other piece is really learning again from history and from our communities around how they are handling and addressing these issues, right? When there is great need, we get creative individually because we have to, right? When you don't have resources, you have to get creative. And you have to sometimes make something out of nothing. And so, when I think about the different kinds of policies we have to constantly be thinking about equity in these conversations, whether it's saying we have specialized training for 988 call centers, right? To make sure that they are talking to people with a version of cultural competency so that people feel comfortable calling. This is why we included in that to have awareness campaigns with certain populations that we know are at higher risk, that maybe they're not going to see a PSA on TV, right? Or they're not going to have a primary care physician who they can go to and will offer them these resources. So we have to be able to be in communities and speak to people in ways that make sense to them, whether that's from going to the grocery store, whether it's, picking up your child from school. What spaces are people, participating in where we can be there to make sure this information is getting to them. So those are a couple things I think the state can do a better job at. And I would just urge, anyone looking at policy to always be looking at it through a lens of equity and a lens of accessibility, of when you create a law or a funding stream, who is it accessible to? And challenge ourselves, right, to reach those who are often inaccessible.
Thank you, Senator. That was beautifully said. Commissioner, would you like to respond?
Sure, thank you so much. And I agree just with everything that the senator said, and especially that equity and inclusion has to be in everything that we do. Traditionally, healthcare has not spent the dollars in places that you're talking about, which is community-based organizations. I mean, our structures and our reimbursement structures are not built that way. And just before I go into what we are doing in the state, I do think that there needs to be a lot of advocacy in that area. You know, there's not an appreciation in our healthcare system of things that are not the traditional medical model and the traditional things that are listed in those lists of whether commercial payers pay for them or Medicaid pays for them. And I think we have to grow past that. And that's why we're doing a number of pilots across the state that we hope can eventually be things that we can move into the mainstream of funding. Because while state funds should go to this, the big bulk of healthcare dollars still sit in insurance. I mean, we have to be honest about that. So the other piece, though, is there's a couple of things that we are doing, and I think that are very exciting. And one is there's $10 million in last year's budget, and it's going to be another 10 million in this year to be doing creative work with youth, with grassroots organizations. One example is like Community Life, which works with Latina adolescent girls in New York City, where they do after school work with young girls who are depressed and really work with them. It's what the medical people call treatment adjacent. It's a horrible term, but it's something that is not exactly paid for. But not. There are 5 of those grants out there. One is at Elmhurst Hospital to work with youth who are dealing with mental health issues. Another one, I believe, with BNS, and another one upstate. We also have a exciting pilot working with Black churches in Harlem, which is expanding to 12 churches statewide, including one in Rochester and upstate. And that pilot is really working with the pastors and everyone to really, it's fascinating. Ms. Matlock, Dr. Matlock, I'm sorry, who's the head of, who's designed this, is working with pastors to put into their sermons important things about mental health and to incorporate that. So I'm using that kind of, as you say, a grassroots connection. And similarly, there's so many grassroots organizations now. So yes, there's these things going on. In addition, these dollars that we have, a bunch of them are going to go for the more traditional mental health, but that's why we're having listening sessions across the state. We want to hear what else is out there because those dollars are movable a little bit, and we can do some of that work that can help other groups come in and do the work that we know are so important for some of our communities. So we're not there yet with what you suggested, Sarah, that there's enough of this going on. But the other thing we sponsored, which I think has been very successful, something called Healing Circles, which has been with psychologists. This is a virtual statewide Sabana Circles, which is based on a method that the Black psychologists have been using and that's available to all New Yorkers. So there's a number of things that we've been doing, not as much as we should, but we're out there doing it. And we're also going to be using in the main dollars that are going, even though stuff that's filled by Medicaid, we're going to be looking at communities that need those services the most and looking clearly at the data and getting input as to how we can even tweak those services, make those services more accessible, more reasonable for BIPOC communities. Because even the services we have, which sometimes are necessary, are not that open often. And so we need that input, and we're going to be working very hard to make sure that those services get to the communities where they're needed. So we're on a journey and we need your assistance and your input.
Thank you. Thank you both.
If I may, I appreciate all these responses. Sorry, Justice. I just want to uplift a couple of policy priorities that Families Together is working on and helping develop that kind of speak to at least part of this conversation, especially around the more flexible funding outside of Medicaid. We're calling for $5.5 million to be invested in flexible funding for things like family peer support and youth peer support, building on that traditional baseline of state dollars. We think if we grew that would really help build up new family peer support programs and help support existing ones so they can meet the needs of families who do not maybe qualify for Medicaid or need a more in and out service, something a little bit more flexible, or unfortunately don't have commercial insurance and don't qualify for coverage for Medicaid for CFTSS services like family and youth peer support. Additionally, we do also we're creating something working alongside Hevesi and Jabari Bridgeport and the child welfare space, building what's called the Child and Family Wellbeing Fund. And the whole idea of that is to build in ways for state dollars to reach community-based organizations that are not the typical players. when money gets brought into the community, that also has a assets-based community development model that empowers families to talk, communities to talk to each other and actually dictate what they want in their communities, not the other way around as we traditionally see funding get pushed out, to speak to some of Sarah's points. So that's something that we really hope gets passed in this year's budget, both those items. And I just wanted to highlight that because I feel like I think we're on the right track. Back to you,
Right.
Justice.
Thank you, Brad. And I just want to highlight the word traditional, right? We're in a space and we're talking about how money is traditionally moved, but also understanding that in these BIPOC communities, tradition looks different, right? What they are traditionally using to uplift and amplify the need for mental health, hygiene, those tradition looks different for different communities. So, and understanding that, right, and how we implement these things is going to look different. So with that, we're going to move to the next question, which will be asked by Victoria Garcia. Victoria,
Hi,
you can introduce yourself.
Thank you for having me. I'm Victoria Garcia. I'm a family peer advocate, and the governor's budget provides funding for new services and facilities. However, we need to make sure that there's staffing at these new facilities. The mental health workforce, especially family peer advocates and youth peer advocates, are overbooked and underpaid, which is causing increased wait lists. And will New York State commit to the workforce funding that youth and families need?
I think in the budget this year, there's a 2.5% COLA, and there was a 5.4% COLA last year. Also in the budget, there is a continuation of the $9 million for loan forgiveness for psychiatrists and nurse practitioners, and an additional $5 million for loan forgiveness for other disciplines, which we will be able to put out soon, and we'll be deciding what those disciplines are. So that's to help build and grow the workforce. The other thing is, over the past couple of years, there's been significant rate increases in so many of the services with the support of the governor that continue and were permanent. Some of this started post-COVID, but many of them continue. It's a 10% increase in the past year in not this year, but past year in clinic rates. There was a 25% increase in CFTSS rates in October, which is permanent and not flexible anymore. It was supposed to only be a startup rate, but that's permanent. That's Children's and Family Services. And in our housing, there's been a 25% increase overall in our residential treatment facilities, in the CRs, in ACT teams. So everything got increases in rates, which also filters to workforce. So I think there's been a commitment to the workforce, and I think it's, I know that individuals are lobbying for a higher COLA, but I do think that there's been a commitment to the workforce and the dollars that are there, and we'll see.
Thank you.
Thank you.
All right, and we're gonna move into the next question. Next up is Tamara Bagal. And Tamara, you can introduce yourself.
Hello, my name is Tamara Bigel, and I'm the parent of a teenager on Long Island. I've struggled with insurance companies over covering my son's mental health care. Between state and federal laws, New York has some of the strongest parity laws in the books. In recent years, New York even passed additional parity reporting bill that was meant to strengthen enforcement. However, for families with behavioral health needs, it feels as if parity doesn't exist. Network adequacy is a myth, and rates of reimbursement for behavioral health are much lower than Medicaid. So many providers don't even accept commercial insurance. What will New York State do to live up to the promise of mental health and treatment parity and hold health plans and commercial insurance accountable?
No, thank you. Parity, it's amazing that parity has been on the books for over 15, 20 years now, and that we are still struggling to make parity really effective across insurance companies. So let me just say what we're doing now to help with that. It won't solve it all, but I think it will help. First of all, for school-based services, and I always think in a way it's interesting that we have to put this in legislation, as opposed to other ways, but we're putting in legislation both an increase in the Medicaid rate for school-based services and the requirement that commercial payers pay for those school-based mental health services. So if that passes the legislature, they will have to pay at the Medicaid higher rate. So we're not only asking them to pay, now I know this is just one piece of the budget, that we also though are put in, if it passes, and this is very, very important to have advocacy for, that emergency urgent services such as home-based crisis intervention, such as CTI teams, such as crisis intervention services have to be paid for by commercial payers. And that is not on the books yet. That's something though that's in one of our Article 7s, that the commercial payers have to pay for urgent, quotes, opposed to emergent, not psychiatric services for adults and kids. So that's huge. That is huge. That's finally saying to the commercial insurers that you have to pay for crisis services, you have to pay for intensive wraparound discharge services, et cetera. And that would then be in law and it would be required. So those are two areas that we are pushing for in this budget. In addition, there is language in the what we call Article 7s to say that there will be regulations coming out that will require network adequacy and distance adequacy. So we will be working on those. If this passes, we will then work on those regulations. And then those regulations can be specifically enforced in New York. So we've been building on parity for a while. A couple of years ago, we passed medical necessity criteria that has definitely improved the ability for individuals to be, used to be, you had trouble, you'd be in the hospital, you have to leave in a day or two because they decided you wasn't medically necessary. Now they have to they have to agree with our medical necessity criteria, not just for hospitalizations, but for outpatients, et cetera. So we've been building and building on parity, but we're not there yet. But I absolutely agree with you. The critical thing here is that there's a responsibility for the commercial payers to pay on a par with what they pay for on the medical side. And there are a number of provisions that are beginning to make a big dent in that in this year's budget, and then we'll continue to fight for that going forward.
Thank you.
If I may, again, Justice, Commissioner, we so support everything, all the provisions that you mentioned. And I guess part of me, my policy brain and advocacy brain is wondering, you mentioned that we need advocacy on this and the governor needs support from the community. Are you anticipating that there's going to be some pushback on those really important provisions when it comes to commercial insurance coverage?
Yes, the commercial insurance, you know, it's hard. What is always the concern, let me just say, the concern of the commercial insurers is that the premiums will have to go up. And the premiums are what everybody pays out of their paycheck for insurance. If you're not talking, if it's not Medicaid and you're paying for it. So their concern is the premiums will go up. I think there's excellent data that this really doesn't raise premiums, that basically this is not a huge cost to the insurance company system. And what it does do ultimately is it prevents the high cost hospitalizations, which are really what they pay out a lot of money for. So if you begin to pay for these services, if anything, it'll be even, it's probably not going to, it's no increase, but it's an argument. And I think that, you know, I've been around a long time, and since the 1990s, the commercial insurers have been saying this, that as soon as you start to expand mental health services, you're going to break the bank and you're going to vastly increase rates. To my knowledge, it has never happened, despite all those protests. So I think it's important to get the word out there, because I think in fairness to legislators, they worry too. They worry, well, what do you mean insurance premiums go up? I mean, that's going to be a problem for my constituents. So I think it's very important to get the reasonable word out there that basically this is not going to cause that kind of thing to happen. And if anything, it will get families, as you were describing, Tamara, who need services, the services when they need them.
Can I just say, Commissioner, how refreshing it is to hear you say those words, because we know that you're leading the mental health system in the state, and it's great to have an ally fighting for us on a policy like this, because you're saying exactly what we've been saying for me. It's been over 20 years of working on Timothy's Law and then continuing with implementation of parity. And our argument has always been that it will actually reduce costs. And insurance companies actually know that, because if they look at, when you look at the policies that, or the programs that they have in place for things like, gym memberships and the sort of the apple a day keeps the doctor away, it's the same thing. So why wouldn't it count for the brain as well? So thank you for continuing to advocate with us.
No, that's critical. And also there is the CHAMP program where individuals feel that they're not getting what they need. And I don't have the number in front of me, but again, we will send it out. That is
Yeah.
sponsored by the state and it's important. So if you feel you're not getting, you can call them, and they do have lawyers on over there that can help actually push through sometimes. And we've been successful in getting people benefits, but you shouldn't have to do that. You shouldn't. It should be a benefit, just like any other benefit. But if you're getting stuck and you feel like you're not getting, then please feel free to call the CHAMP program, CHAMP.
Thank you so much, Commissioner. So we're going to move on to the next question. And this question I will be asking on behalf of Mushrafi Anwar. He is a part of the Healthy Minds, Healthy Kids Coalition. And due to unforeseen circumstance, I'll be asking his question. Most youth spend majority of their time in a school setting. Evidence shows that mental health services have a high efficacy rate when available in schools. We are happy to see that there is some attention given to this, but it feels incomplete. There's room for improvement, and we need a more universal approach. How is New York State committing to the schools being a space for healing and growth, but also expansion of the schools-based mental health services? And do you envision a bigger role for family and youth peer advocates in this space?
Well, first of all, I do think we should have many more youth and family advocates in the space. And I think hopefully by having youth and family advocates, I know it's billable, I hate to say this, but billable by Medicaid, it enables us with the satellite clinics that we're putting in the schools to increase that and to make it happen. Now we have to work with the providers who are putting clinics in schools. So basically the issue here is that I think every school in New York State should have a mental health clinic. And that means that we have enough providers across the state who can offer a school a satellite clinic in that school. And if we get this bill passed, where commercial payers and Medicaid both have to pay at the higher rate, these school-based services become viable. We've looked at it very carefully. In some ways, we weren't paying quite enough even for Medicaid, so we upped the rate. And if we require the commercial payers to pay, it should be able to make school-based services really viable and enable. So every school, and we've been out there pitching this to the schools, and if anyone knows schools who are interested who somehow haven't been able to connect with us, please let us know. We will work with any school. We have some dollars for what we call startup, so that you don't lose too much money as you start it. But they should be viable, and we would love to be able to work with schools. Now, what's a mental health clinic mean? It can mean different things to different schools. And some schools have multiple days where someone is there, a social worker or a counselor. Others do it maybe a couple of days a week. Others do it. They can design it to what the need is of the school. But the good thing about it, and we use telehealth too, which works very well for some consultations. The good thing about it is it links back to a provider in the community. And that provider in the community should be well respected by the school and the community. And then if someone needs more than school-based, that provider in the community is there to provide it. So it provides not just the service in the school, but the link to something else if you need it. We have 1,100 now. In 1,100 schools, we have school-based mental health clinics across the state. I think we have something like 6,000 schools. So we're not there yet, but we're inching up to the numbers of schools. And especially, I think every school should have it, but especially our high schools and our middle schools. We've been pushing very hard to get these in. So I think that's one big thing. The other thing is some schools, I think, need also assistance in the culture of the school being something that is open and welcome for mental health issues. So that's something that we've been also funding some grants jointly with the Department of Ed for schools. And we've picked out schools that we felt were under the most stress. So schools that were in the areas of the pandemic and schools that were in underserved communities, and offered them the opportunity to go for these grants instead of just making it statewide, because then, some of the richer schools, I don't mean to say rich, but some of the more some schools are easier to write for things, and so they get them. The thing we were talking about before, equity and inclusion. So there are those dollars coming out. And then we do all kinds of work in schools also. For example, we're looking at something which we've put $1 million in this budget. If it's helpful, we'll continue called teen mental health first aid. And teen mental health first aid is really teens in the schools being trained with mental health. What's important, how do you relate to your fellow student? Similar to what we call general mental health first aid, but it's focused with teens and with teens working with teens. So we're going to be expanding that across the state. So there's a number of things that we're doing in the schools as well, because you need a mental health clinic, but you also need a culture of healing, a culture of openness in the schools. So that's the other thing that we're working with some schools. How do you kind of do that so that people feel safe and open, and if they do have mental health issues, they come forward. And then we're doing some very special projects also with the LGBTQ community, because those students are some of the highest risk students in our schools across the state. And how can schools work with them to help them feel, again, more comfortable, more open, you know, and a lot of what we do in the schools in this regard also deals with things like bullying and some of the things that shouldn't be going on in schools. So I think that we're growing that, because I absolutely agree with you and the young person who asked the question, that schools are a wonderful place to intervene, also to educate, also to, it would be wonderful if everyone who graduated from our school system now as an adult didn't live with the stigma of having a mental health problem, felt comfortable asking for help, knew how to get it, and understood what it meant if you were going through a crisis and how you might need help. And I think we're getting there. And I think some schools, just one more, my grandkids are in the public school system in New York City, and they come home with social emotional, I call them that, they have other names for them, social emotional wellness exercises that they do. And I just think that's terrific, because I think that it starts at an early age, making people aware of these things, and the kids, and then they bring it to the parents. Now, one more thing, the other thing you mentioned, in the schools, I don't think we've been connecting enough with the parents. So I think that's something we have to do. And I think the best way to do that is to begin to incorporate some of the parent advocates and youth into the school-based services. So we haven't been as good as that. And we want to make sure that as we grow these school-based clinics, we're better at that.
Thank you so much for that answer. And Justice, again, I'm just going to, so there's a few pieces that I feel like I want to respond to and also hear a little bit more about from the commissioner on. I think one of the challenges that we've heard when we're talking about family peer support programs engaging with schools is, you know, if we're talking about like the joint funding that SED and OMH have been putting out for kind of general capacity for school-based mental health programming, is that there's a finite amount of money going to that school. And sometimes the schools have an attitude towards parent advocates as an adversary, especially when we're talking about, you know, manifestation hearings and special education committees. You know, sometimes it can feel like, and do they really want to pay for the advocates who are going to make parents more confident and the young people more confident in their conversations, where they're asking the school to pay more for services that should be in the school to support the young person seeking their education. And so when I hear, you know, there's like a hope of let's get CFTSS rates it up, and maybe that will allow for more parental advocacy. But I think there might need to be separate funding that helps programs build up and kind of act independently and not necessarily have to be going through the school to do that. And just kind of recognizing that the schools aren't necessarily wanting to fund who they see as adversaries, unfortunately, in some cases. I'm wondering if you have any thoughts on that.
Well, I think you're bringing up a very important point, and I think hopefully also when I think about the mental health system, for many years we were very. If I go back in time, we were afraid of advocates. You know, we didn't want them around. We felt that they were going to cause all kinds of trouble and tell us do things we want to do, and they were going to. And you know, we had to learn. and part of what you're saying, I think, is so true. But I would love to see if we could, even with our school-based services, try to help the schools understand this: that advocates are not their enemies. That advocates are there to help them really understand how to do things better and how to make sure people get what they need. So that's just one piece. So I'd hope we could do that. I think the other piece, though, as you say, is that doesn't happen overnight. You know, you can't change culture like that overnight. I do think that partly having them as part of the clinical service in the school, connected to, let's say, the social worker or something, might help the bridge there a little bit. If people can, but again, I think we probably have to help people understand how to do that, how to train people to know how to do that. Just like we had to train people to know how to have people lived experience in our clinics. People didn't just open the doors. So I think we have to work at that. And then your point is well taken, that to some extent, there's always going to be a need for advocates to be independent of the whole thing, and have a role that is not tied to any place. So I think that depending upon the situation and what's going on, but I think there's probably a place in all of those, including the, as you said, the totally independent role.
Thank you.
Thank you, Commissioner. So next up, we have Melinda Agnew. Melinda, you can introduce yourself.
Hi, good afternoon, Commissioner Sullivan and everybody else that make up this call. My name is Melinda Agnew and I am from Syracuse, New York. I am a mother of 3 children who have mental health diagnosis, and I am a family policy advisor for Families Together in New York State. A consistent theme that I've experienced in my family and the families I work with is struggling to find community-based services and resources before issues escalate into crisis. My youngest daughter is now involved in family court probation and recently being admitted to a RTF. But the time between when we knew she was struggling to the crisis point we find ourselves in now were years of missed opportunities. We see that the governor wants to invest $1 billion in mental health, but much of that looks like it's for beds and facilities, maybe for adults instead of children, and perhaps concentrated in New York City and not upstate communities. How much of these investments will actually find their way into behavioral health services for young people in communities like mine and beyond that? And what are we doing to ensure these services are genuinely engaging for young people?
Yeah, thank you for that. And you're absolutely right. We have to be sure it happens the way you asked your question, that it gets into the communities that need the services, and that it gets in such a way that people feel comfortable using the services. So we really need your feedback, and that's that's why we're setting these meetings up across the state, to hear from you, from grassroots organizations, from hospitals, from everybody, what's not working. The commitment of the governor is to put a lot, and we as well, to put a lot of these services into youth-based services. So, for example, the home-based crisis intervention, which I think most people feel is pretty effective, however, probably still needs to be tailored to some communities, and we have to work on that. I think we have like 3,600 slots now. We're going to be going up to 4,500 across the state, and those will be spread across the state. We have 20 Youth Act teams. We'll be going up to something like 30 Youth Act teams. And where do we need to put those? And how do we, and every Youth Act team has a youth advocate and a family advocate. How do those go out there? How do they get across the state? It's critical that it will not all by any means be in New York. It's going to be evenly divided between New York City and upstate. But we've got to know real it's very needed. And also if there are communities that need it, but we're not doing it in a way that they will accept it, then we need to figure out how to do that. We can't just say, so just a simple cockamamie crazy thing that we did was we say ACT teams, for example, have to follow this evidence-based practice. So we say you have to have so many people, and in order to support so many people, you have to have so many individuals. Well, that doesn't work in rural upstate New York. I mean, it just doesn't work. So upstate New York often stopped applying for ACT teams. So we made it flexible with the Youth Act, and we're going to now make it flexible with all the ACT teams. We have to rethink how we do it, and that's what we need. So the dollars are there, but the models can be flexible. And the important thing is that a really big chunk of this. Now, part of the huge gap that we've traditionally had is that when that crisis occurs, and I'm so sorry you had to wait so long, but we have this crisis where someone needs something, and we say, okay, fill this out, wait 3 weeks, then maybe make it a little bit longer, and then we'll finally get you whatever you need to say. So you have the magic slip that can get you. We need to have things when somebody needs them. And that's where this infusion of services is coming from. So that's why we have additional, what we call critical time intervention teams that will work with families as well. So if someone is in a crisis, they can get that help. Similarly, the stabilization centers, they're not all up yet, but they will be across the state. They will be immediate access as well. 988 should, if we continue to push it and work it right, should be a line that anybody can call and get to where they need to get. And then we're going to be tripling this certified community behavioral health centers. And the certified community behavioral health centers that have gone up across the state, the 13 original, one of the biggest increases they all made was in child services and youth services, partly because they were funded to be able to do that. You know, they had the backup money to do it. So we expect the same thing of the additional ones. So while it's going to take time, it can't all happen overnight. The other thing is we are growing the crisis residence beds, and those housing units that are going up, a whole bunch of those are going to be for transition age youth, for young youth who need to be have their own place and be out, but also transitional beds for younger youth as well. So believe me, we're going to be, but we also need your input as to where it's needed, what's needed the most, and how we have to be more effective in reaching out to certain communities. But thank you. You're absolutely right. We haven't been there yet, but we're going to get closer. I think we're going to get a lot closer to doing exactly what you said.
Thank you so much, Commissioner Sullivan.
Justice, I think we're out of questions, but I think I have a few in the hopper that were left on the shop floor. If we want to spend a little bit extra time, it can answer maybe one more from that space. And this would come up, if you don't mind, Commissioner, so I'll ask it. So you don't mind, right, Paige?
He's an advocate.
So last year, or our first town hall was yesterday, and it was focused on addiction and recovery. And we spent a lot of time talking about really, the past push from Governor Cuomo, and I believe the Senate to merge OMH and OASIS into behavioral health agency. And the main intent behind that, right, is to make sure we have integrated care that is recognizing that so many young people in the addiction space have a comorbidity in mental health and vice versa. And that the experience of families is that they're not getting, they might need, the young person might need both, they're not getting both, and that the system treats them as two different people, even if that one person is experiencing both things concurrently. So we had talked a lot about this yesterday, and I'm wondering, of this, are you sort of seeing, and the governor sort of recognizing that issue, even if a merger isn't going to happen? Like, what are we doing? What's OMH? How is OMH thinking about comorbidity among addiction and mental health? And we'll start there. I know there's other people also thinking about developmental disabilities. So like all those different ways that young person doesn't fit into one single system.
Yeah, sure, absolutely. And I think, what we're working on, and certainly I think the model for the crisis stabilization centers, where we jointly put those up between us and OASIS, and anybody who walks in that door, youth, adult, should be able to be treated equally as one person for mental health and substance use. So sometimes it's easier to do that with new stuff than with changing culture in the way certain things work. So stabilization centers, all these new programs that we're putting up, take the critical time intervention teams or the ACT teams, that the new ones we're putting up are all going to have integrated care. So they're all going to be able to work with individuals with us who have a dual diagnosis of mental health and substance use. We're also pushing it into with the CCBHCs are required. The stabilization centers are, the new services coming up will, and we've also been talking with Carrie Neifeld at OPWGD, so that individuals coming into the CCBHCs and our crisis system that we train, and we've already got some training lined up for people to be able to start to be able to deal with individuals who have a dual diagnosis of mental health and developmental disability. I think, whether you merge agencies or not, and I've talked to commissioners who merged agencies and commissioners who haven't, unless you do the hard work on the ground of making sure that people understand, that people don't want to say I can't do it, but they don't know how. They haven't been trained often. That's been a lack in our systems. And that's the second thing we've got to get to eventually, which are the educational systems, so that when people graduate, we're not teaching them to be integrated care after they graduate, but they learn integrated care while they're in school. But for us, we have to do it now after people have graduated. So we have to make sure that that training is there and make sure that people understand. Now, there's times when someone might go more towards substance use and sometimes more the other way. We have to have all those services available, but things like our CCBHCs, our crisis services, stabilization centers, they should all be integrated care. They're not now, but they're getting there. They're getting there. And I think that, in a fair number of our CCBHCs, we've had some good reports, certified community behavioral health centers. We've had some good reports of that integrated care working pretty well. So I think that we kind of know how to do it. We've just got to make sure that it happens and we get it out there, because it hasn't been good. It hasn't been good for the individual and hasn't been good for the families. So we're working very hard at it. And I know Dr. Cunningham is very committed to this as well. And even with the opioid dollars that are coming out, we're meeting all the time about how, and I would just like to make a pitch for that for providers, that there are some dollars coming out for integrated care and stuff that are coming out of the OASIS side that are LMH clinics are eligible for. And we want to make sure that everybody sees that and knows that, and we're pushing that out as well. I think we're getting there. And I think the new services can be a big jump start for that, because if you put it into new things coming out, you can begin to change the culture more rapidly.
Thank you, Commissioner. I know at the beginning, thank you, Justice, so much for being the leader of this whole town hall. You've done a great job, and I appreciate, Commissioner, also that you invited Sarah Caracas to join from your staff, because she's the expert on children and families over at OMH, and we are very appreciative, Sarah, of your partnership on all of the work that we do together, and also of the understanding that you have. And I know that you and Commissioner Sullivan both serve as allies and champions for us on all of the things that we want to have done here that we talked about today, and that we've talked about with all of you, with both of you over the years. Unfortunately, the senator had to hop off. Her phone was dying, but also she was in session, and the Assembly member Gunther had the same issue. So we're going to send our questions to, I wanted for the panelists and the folks who asked the questions to know that your questions are going to be sent also to the legislators for them to be able to respond, and hopefully they'll have time to get back to us so that we can share those responses with you and with our members. Sarah, I want to just give you a chance to say hello if you had anything you wanted to say.
Such a pleasure to be here and consider all of you such allies. It's a real pleasure to particularly be putting the youth peer and the family peer workforce, infrastructure, advancement, etc., at the core of the work that we're doing. As Commissioner Sullivan mentioned, it's so critical for us that particularly anything new we roll out, we have a commitment to not do it without peers. Any new model, every design. And as Commissioner Sullivan mentioned, we do have work to do in ensuring that the existing models do have good peer infrastructure built in. But I want you to know and to reinforce what she said, that we absolutely see that as pivotal, the way of the future.
Thank you. And I wanted for both of you to know that the members, our members, the young people and family members who are watching today, and this will all be on our website as our past town halls have been. So they will be, this will be seen by hundreds more people. So everything that we all are hearing today from you is also going to be shared with many other family members and young people across the state. And I just wanted for all of them to know how much we appreciate the partnership and the ability to strengthen the infrastructure of peer support across the state. Thank you for your time and your energy.
I would just like to thank you all one more time, because you know you're there every day doing such great work across New York with individuals, families, and youth who need our help and your help. So thank you, thank you. I know it's tough work. I know that it's draining. I know that it takes a toll. But your commitment and your caring, it's all from the heart. So thank you. Thank you so much for what you do every day.
Thanks everyone for joining. And we have three more town halls, 4 more town halls coming up. And I don't have them in front of me. Brad, do you have the dates so we can tell people to watch for? Oh, I do have them in front of me. Youth
Should
Justice
have it
Town
better.
Hall.
Yep.
You go ahead.
I said I should have them committed to memory by now, but so next week we're focused on child welfare and youth justice. Our youth justice town hall will be on the 7th at 11 a.m. And then the next day is going to be the child welfare town hall. And then the following week we'll have developmental disabilities and education to close things off. So we're gonna have some really great conversation. 3/14 at 11 a.m. is developmental disabilities, and Friday 3/17 is education. And then we'll close everything out. We're going to be having a rally, a advocacy day at the Capitol, March 21st. If you can only join the rally, that starts at noon. We'll be marching over the State Plaza, calling for more investments in youth mental health and child family well-being overall, youth justice, child welfare. We have a big agenda. We have some great people coming, over about 200 people registered coming from across the state. And so we're so excited. And if you haven't signed up yet, please do. There is some space left. I believe we have 5 buses across New York. So make sure you get your seat.
Thanks again, everyone.
Thank you.